Good morning, ladies and gentlemen. I'm Isha Nirvan, your host, and I would like to render you all a very warm welcome to AIOC 2021. Without any further ado, let's get started with the session. I would request the chairpersons to unmute and switch on the camera, starting with Dr. Rajiv Kumar Gupta and Dr. Jagdish Rana. Over to you, sir.
Okay. So, good morning, friends. I welcome you all on behalf of the All India Ophthalmological Society. So, we will start with our first presentation, that is by Dr. Lieutenant Colonel Dr. Jyoti, pterygium excision with autograph without glue sutures using diathermy. So, over to Dr. Jyoti.
Good morning, sir. Good morning, everybody. Firstly, I would like to thank AIOS for giving me this opportunity. I would like to share my screen. My topic is pterygium excision and autografting using diathermy. We all know the pterygium, a degenerative condition of the subconjunctival tissue.
Ma'am, your screen is not visible.
Is it visible now?
No, ma'am.
Yeah, now is it visible?
Yes, ma'am. Okay, continue.
So, pterygium excision and autografting using diathermy. This is the topic which I'm going to address, and this is a novel technique which I have discovered, and I thought I should share it with the August forum like this. So basically, we all know that pterygium, a degenerative condition of the subconjunctival tissue which proliferates as vascularized tissue and slowly progresses to invade the cornea. It destroys the superficial layers of the stroma and the Bowman's membrane. So etiology can be exposure to sunlight, especially UV rays, and tropical areas of activities are the usual etiological factors. Theories say that it is a genetic thing, but it is a very common condition, and all ophthalmologists have to face pterygium, have to treat pterygium, and it is so common. So the symptoms, the patient may be absolutely asymptomatic. It could be a cosmetic worry, or it could be a refractive change due to encroachment in the cornea. Sometimes it may be inflamed. There may be a gross diminution of vision if it covers the pupillary area. All these symptoms are often encountered, and the patient may demand surgery at any stage. Now, surgical treatment, that is the bare sclera excision and leaving the sclera without any covering, is the one which we have been doing for a very long time. It is certified now that the conjunctival autografting, the sclera is covered with the patient's own conjunctiva, usually from the same eye, which is held using sutures or tissue glue. The new technique described here is using diathermy. The idea basically came from things. Firstly, I've seen welders, weld at some places and the work gets done. And here we are dealing with a live tissue where conjunctiva has got an awesome healing property. So one of these days when I had a lot of cases, I thought, let me try and just do the diathermy at a few places and secure the cornea. We have been doing diathermy for ECC cases when we replace the conjunctiva at the end of the surgery and cover the sutures. So in the same way, at different places, if we can just put the cautery, drying the conjunctiva, both holding the two edges well and applying the diathermy. It may be required that if it's a large graft, at a few more places we may have to do it. And I left it like that. And then I realized that it was really working well. So about 100 cases of pterygium were selected. Cases with other ocular diseases were excluded. And the mean age of the patients was 46.6 years, 30 to 68 years. Other comorbidities like diabetes, hypertension, adequately controlled. All cases were pre-operatively evaluated for blood counts, ECG, whatever is the pre-operative protocol which we follow for all cases. All cases underwent pre-anesthetic checkup and posted for surgery under peribulbar anesthesia. After that, removal of the pterygium was done. After cleaning and draping, peribulbar block given, pterygium is infiltrated with 2% lignocaine. Excision of pterygium given by holding the neck of the proliferative tissue, detaching the head from the corneal surface. This technique, actually, if you just do it like a rotation, it gives a very clean corneal surface. Of course, after that, the cleaning was done with a crescent. The main exercise, after securing hemostasis of the bare scleral bed, the measurement of the scleral bed using calipers was done. 0.5 centimeter larger graft marking at the superior limbus was done. 0.5 centimeter the overall. So each and every edge would be around 2 to 2.5 millimeters bigger than the bed, the recipient bed. The superior limbus is infiltrated with 2% lignocaine, raising the conjunctiva and leaving behind the tenon capsule. The graft is dissected, leaving behind a small attachment. This helps in orienting the limbal side to the recipient recipient limbal side. We attach the graft, slowly sliding it over the cornea to be placed on the bare sclera side, taking care that the limbal edge approximates with the limbus. The edges of the donor graft are approximated to the recipient side to the edge of the conjunctiva with diathermy, 4 or 8 spots of attachment depending on the size of the graft. At the end of the surgery, subconjunctival injection given and dressing down patch given for 24 hours. If required, after 24 hours, when you remove the patch, if you feel there is still any requirement, you can give it for even 24 hours more. And post-operative care using steroid and antibiotic topical drops 8 times a day for 1 week, followed by 4 times for a month. Out of the 100 cases, 98 patients were followed for a period of 1 year and 75 patients for a period of 2 years. The patient showed good post-operative recovery with minimal pain for the first week and subsequently became totally asymptomatic. Very little watering seen for the first 1 week. The graft remained well attached and good post-operative recovery. There were no cases of recurrence. Removal by bare sclera technique is known to have a high rate of recurrence. Universally, it is acknowledged that autografting is the best way to treat pterygium, which was first described by Kenyon and others. Securing the graft with sutures is a time-tested method, but it is time-consuming and tedious. Causes a lot of discomfort and irritation to the patient. Using tissue glue, tissue fibrin glue is also a very good solution, but it is expensive. To give the advantage of a conjunctival autograft for a case of pterygium without much cost, this technique, I feel, is a good alternative. It's very simple, very easy to master. There is no additional cost. It is quick, no recurrence, and good postoperative recovery, no irritation, and high patient satisfaction. There are no side effects, and it is extremely effective. So, hence, in conclusion, I would like to say that looking at the effectiveness and the ease of procedure, this procedure may become the latest in the way of treating pterygium. Better results, cost effectiveness, and lack of complications, low learning curve, and simple solution to large problems. Thank you.
So much, Doctor.
Any questions from the panel members?
Yeah, Dr. Jyoti, I think very innovative presentation. As you have told, we have been using this technique for cataract surgeries. I hope you remember me, madam. We met in Vizag.
Yes, sir. Yes, sir.
Okay. Very nice, ma'am. Very nice.
Thank you so much, sir.
While they are doing the diathermy,
sir,
are you diathermizing the bed also, the scleral bed?
No, sir. What is happening is, first, when we remove the pterygium, we are making the bed as clean as possible.
Ma'am, I'm so sorry to interrupt. Ma'am, I'm so sorry to interrupt. The Q&A will be at the end of the session. Thank you so much for finishing in time. And I request the next speaker to please start sharing the screen and we shall go further. Thank you so much, ma'am. Thank you so much, sir.
Thank you.
Over to you, sir.
Our next speaker is Dr. Vinod Kumar, presenting a toxic epidermal necrolysis, and there is don't ignore eyes. So over to Dr. Vinod Kumar.
Sorry, sir, Dr. Vinod is not available right now.
So we'll move to a next topic. Dr. Vijaya Jojo. The COVID-19 lockdown era, the effect of work from the home and incidence of computer syndrome. Dr. Vijaya Jojo is there?
Yeah. Yes, sir.
Please,
Just
over to you.
share my screen.
नेहा, अरे भाई इधर देखो कोई एक आदमी उधर पे है नहीं.
My screen is visible. Is my screen visible?
Not yet, ma'am. Just
Not
give
yet.
me. Yeah.
Yeah,
Yes.
yeah,
Now
yeah.
it is.
Yes, it is visible now. It's visible.
Let's go to the presentation mode. And I'm audible enough?
Yeah, enough.
Right. I'll start then.
Yeah, okay.
A very good morning to Chairperson, my other speakers in this session, my seniors and colleagues here. So the effect of work from home and the incidence of computer vision syndrome during this COVID-19 era is what my paper is based on. Now, as we know, the COVID-19 era has brought in an increased dependency and the usage of various digital devices, not just for IT professionals, but for everyone in general. And the idea thereby, or the aim of my study was therefore to assess the incidence of computer eye syndrome during this lockdown era, which was last year, and to compare it with the pre-existing data that already exists, which is in the pre-COVID era. So what we did was a cross-sectional study using a questionnaire, which was the CBSQ questionnaire that I've added at the as an annexure to this presentation. And it included 16 symptoms, which were then also assessed on the basis of the frequency of the symptoms as well as the intensity. They were then multiplied and totaled to yield a score. Accordingly, those patients with a score of more than 6 were supposed to have dry eyes. We further divided the hours of usage into group A, those who used it for any kind of device for less than 2 hours, group B who were from 2 to 8 hours, group C who were for more than 8 hours. We had a time period of May 1st to 31st May. This was, if you remember, the time when we had the strict lockdown time brought in by the government of India. And we had a few patients visiting our IOPD. We included all above the age of 18 visiting for routine complaints. We, however, excluded patients with any pre-existing corneal pathology to avoid any errors in our assessment. We also incorporated not just the usage of laptops and other devices, but also asked in a small point asking the number of hours they use their mobile phones as well. So we had a total of 107 patients with an age group from 23 to 74 with a mean of 43.4 years. 48.5% of patients in this group mentioned that they suffered from various symptoms. The 16 symptoms are there in my chart down here with the frequency associated with that. And the mean use of digital devices range was around 3.82 hours per day. Of these symptomatic patients, 73% of these patients mentioned using digital devices of any type for more than 2 hours at least. And those, however, 39% of patients mentioned that they had used it for more than 8 hours, showing that the increased duration of usage was associated with more frequent symptoms. We also picked up that the mobile phone usage in this period has increased, though the numbers were not good enough to go in larger into a very big scale because we had only a 1 month study. Headache was noted as being the commonest symptom in all these 16 symptoms that we had. Which brings me to my discussion. As we know that we all as ophthalmologists have studied, and we know that there are multi-factors and a lot of factors which contribute to dry eyes, of which the use of digital devices is supposed to be one very important or a predominant factor. The current literature says that there is an incidence between 50 to 90% of IT users, primarily IT professionals, and their common symptoms, as mentioned there, were the common astigmatism. However, in this recent change where we've shifted our working pattern from an office-based situation to our work from home, and also the increased dependency on digital devices for not only work, but for recreation and otherwise, there's a change in work pattern. and we only found the studies that the results were quite similar to what pre-existing. The mobile phone usage has slowly come up as a new factor. In conclusion, thereby, even though we know that dry eye is known to occur with the use of computers, where it existed even the pre-COVID era, we did not find a very huge change in this particular time period. We have, however, pointed out that mobile phone is coming up. We will look at this in a larger study in time to come. We need to improve and advocate practices aimed at reducing the symptoms to help our patients to work in a more symptom-free and a happy environment. Thank you very much. I have my annexure here where the symptoms, this is what I have provided my patients. They filled it themselves and we calculated and put in terms of our study results. Thank you very much.
Thank you, Dr. Vijaya, for a nice presentation. Now we'll move to
No, I mean, do we have time for a few questions? Or?
No, actually, after presentation.
Sir, we'll be taking all the questions post
at the end.
presentation.
Okay.
Yes,
Yeah.
thank you so much.
So our next speaker will be Dr. Sukanya, presenting a pterygium surgery, comparative study of modified procedure with mitomycin C versus amniotic membrane graft. So over to Dr. Sukanya.
Good morning, sir. I would like to share my screen. Is the screen visible, sir?
Yeah.
Yes.
Yes.
Okay, good morning, everyone, to the respected judges and the panelists here and my colleagues. I'm Dr. Sukanya Gore and I'll be presenting my topic on the comparative study of modified procedure with mitomycin C versus amniotic membrane graft for pterygium excision. Now we know that pterygium surgery with bare sclera technique is associated with recurrence, which is as high as 24 to 89%. Now, various adjunctive treatments have been used, which aimed at inhibiting the fibroblast proliferation, covering the bare sclera with a tissue of similar properties. Now, amniotic membrane possesses anti-scarring, anti-angiogenic, and anti-inflammatory properties, which may be useful for treating the pterygium. Also, mitomycin C is an antimetabolite antibiotic agent that selectively inhibits the synthesis of DNA, cellular RNA, and protein, and hence affects the cellular proliferation for a long time. Now, the aims and objectives of my study were to compare the outcomes in the modified surgical procedure using mitomycin C versus amniotic membrane graft for pterygium excision with respect to recurrence, complications, and the surgical time. Now, it was a hospital-based randomized controlled trial. 164 patients were included and they were divided into two groups. 82 underwent modified procedure using the mitomycin C and the 82 underwent amniotic membrane grafting. I had included patients who were above 18 years of age, had nasal as well as temporal pterygium, like either of them, then grade 1 to 3 of pterygium, and those who are willing for follow-up. Exclusion criteria were any recurrent pterygium, pseudopterygium, any previous ocular surgery within the past 6 months, ocular morbidities such as corneal degeneration or dystrophy, dry eyes, corneal opacities and scarring, and advanced glaucoma. The group 1 underwent modified pterygium excision using mitomycin C and group 2 underwent pterygium excision with amniotic membrane graft. In both the groups, the duration of the surgery was calculated from the time after securing the superior rectus suture up to the time the lid speculum was removed. All the patients were discharged on the first post-operative day and were examined after 1 week, 1 month, 3 months, and 6 months. Then during the follow-up, the patients were examined for the recurrence of pterygium, the possible side effects of mitomycin C, and if any graft complications were present. Now, in my study, the mean age in the AMG group was 54 years and in mitomycin was 55 years. In the AMG group, out of 82 patients, 44 were females and 38 were males. And in the mitomycin C group, out of 82, 47 were females and 35 were males. The mean duration of surgery in the AMG group was observed to be 33 minutes and in the MMC group was observed to be 17 minutes. The difference between the two groups was found to be statistically significant. The complications which were observed were in the AMG group, graft retraction was seen in 2 cases and graft inflammation was seen in 1 case. And in mitomycin C, corneal thinning was seen in one case and granuloma was seen in one case. The recurrence was found to be equal in both groups. There were 2 cases of recurrence in each groups. There was no statistically difference regarding recurrence in either of the groups. Now, in our study, the pterygium excision with amniotic membrane graft was compared to the modified procedure with mitomycin C, both of which are known to reduce the rate of recurrence. Now, the duration of the surgery with amniotic membrane graft was significantly higher than using the mitomycin C. In mitomycin C, 1 case had corneal thinning and 1 case had granuloma formation. And in AMG group, 2 cases of graft rejection and 1 case of graft inflammation was seen. No other site-threatening complications were encountered in either of the group. Now, similar complications were also seen in the studies which are quoted below. Now, in the present study, there were 2 cases of recurrence in each of the groups. So my conclusion is that both the techniques had comparable minor treatable complications. Both of them were equally effective in reducing the recurrence rate. However, shorter surgical time, cost effectiveness, lesser post-operative inflammation, cosmetically better appearance, and meticulous use of intraoperative mitomycin C with lesser contact time makes a modified surgical procedure with mitomycin C an effective option for pterygium excision. These were my references for the study. Thank you so much.
Thank you, Dr. Sukanya. It was a very nice presentation. Yeah.
Thank you, sir.
Now we'll switch over to the next topic from Dr. Anuradha. External ophthalmoniasis, a series of 3 cases from a residence area in Punjab. Dr. Anuradha.
Good morning, sir. Am I audible?
Yeah, you're audible. Yeah. Now start sharing.
So is my presentation visible?
No.
No.
I'm having some trouble sharing my screen.
No worries, ma'am. Sir, can we continue with the next speaker? Ma'am, by then you can fix the problem and we can get back to you later.
Right. Thank you. Thank you.
Thank you so much, ma'am.
So next speaker is Dr. Pooja Kumari. Keen solve the mystery of an eye, a rare case report of Behçet disease.
Morning,
Dr.
sir.
Pooja Kumari.
Am I audible?
Yeah.
Are my slides visible?
Yeah, it's visible.
Good morning, judges, my dear colleagues. I'm going to present a rare case report of Behçet's disease. So I've given a topic of skin solve the mystery of an eye. So we'll just go ahead with the case. The patient is a 13-year-old female who presented with sudden onset diminution of vision in left eye, more than right eye for past 10 days. And it was associated with redness, mild pain, photophobia, and prurient discharge. And there was also swelling of both the eyelids. So history of present illness goes like patient was apparently asymptomatic 10 days back when she noticed sudden onset pain, redness, discharge, and diminution of vision of left eye. And after 3 days, she was complaining of similar symptoms in the right eye. And she also noticed that she had some painful ulcers over the finger, foot, scalp, oral cavity, and genitals on the 3rd day. So she consulted outside in the private hospital, and there they have diagnosed her with acute mucopurulent conjunctivitis, and they have given a diagnosis of gonococcal conjunctivitis. And they started her on topical fortified antibiotics as a cefazolin and amikacin eye drops. But there was no response noticed, so she came to RPC for further management. So on further probing, we took a history of a fever or any systemic illness, but she denied any history of fever. There was no similar complaints in the past. There was no history of any ocular trauma. There was no history of any drug or food allergy. There was no history of any vascular events or any deep vein thrombosis in the past. She was not complaining of any hematuria or any blood in stools or bleeding from nose. No history of consanguinity was there in the family, and there was no similar complaints in the family. She had 3 elder siblings, and all were fine. There was no similar complaints in the family, and she has not attended menarche till now. Coming to systemic examination, patient was conscious, cooperative, oriented to time, place, and person. And on systemic examination, we saw that there were multiple well-defined ulcerated skin lesions with clear margins, which was noticed over fingers, dorsum of foot, scalp, oral cavity, and perineal area. And mild discharge were also present. Other systemic examinations such as cardiovascular, respiratory, central nervous system, and GI examinations were normal. So this was the clinical picture. Here we can see she had one oral aphthous ulcer over the tongue, and she was also having angular stomatitis. Here we can see a ulcerated lesion on the scalp, that is back of the neck, and crusting was also there over it. This was a lesion which was present over the finger with clear margins, and this was the lesion which was present on the dorsum of the foot. Now coming to ocular examination, her uncorrected visual acuity in right eye was 612, which improved with refraction to 6.9 with minus 1.25 sphere and minus 0.25 cylinder at 90 degree. Intraocular pressure on NCT was 18 millimeters of mercury, and eyelids we saw marked edema was there with matting of eyelashes. There was no entropion or ectropion. Conjunctiva was diffusely congested, and it was boggy in nature, and mucopurulent discharge was there. After clearing the discharge, we could visualize the cornea, and we could see that it was normal in shape and size, and surface was regular, and sensations were also normal. There was no scarring. Coming to examination of left eye, visual acuity was hand movements close to face, and projection of rays were accurate in all 4 quadrants. For other examination, similar findings were there in the left eye as well, but she was not very cooperative for examination, and so we had to take the child for examination under general anesthesia. This was the presentation when she presented to us. So here we can see mucopurulent discharge is there, and conjunctiva is also appearing boggy, and when she has opened her eyes, we could hardly see cornea. So after clearing the discharge, this is the picture of the right eye, and this was the left eye. In left eye, it was very difficult to remove the discharge, as it was very much adherent to the conjunctiva, and a symblepharon like picture was there in the nasal area. So other examinations were of right eye were within normal limit. Fundus was also normal. There was no evidence of any vasculitis, but we could not examine the left eye. So we took the patient for EUA, and this is the EUA picture. So inferiorly is the superior part, and this is the inferior part. So here we can see this is the there was 360 degree of scleral necrosis was there with avascular zone, and here around 7 to 9 o'clock there was a necrotic area with uveal tissue prolapse was present, and 360 degree peripheral ulcerative keratitis was present. So we sent certain investigations to dermatology and rheumatology, and they have advised a list of investigations. Ultrasound was normal, and conjunctiva for microbiology we had sent for both gram staining, fungal culture. Everything was normal, no growth was seen, and on systemic examination also most of the investigations were normal. Chest X-ray was also normal. For syphilis investigations was also normal, and viral serology markers were also non-reactive. Other investigation also we did not find much. ANA, RA factor, ANCA was negative, and HLA profile was also negative. Dermatology, they had advised for pathology test, which also came for negative. So treatment was started. From dermatology, they had started Dapsone 50 mg OD, and prednisolone was started 20 mg OD. And rheumatology people, they were suspecting vasculitis sequelae, so they told to start immunosuppressants, and they added azathioprine 25 mg OD. And for local application, they had given Candid cream, and blood investigations were closely monitored as the child was subjected to immunosuppressives. And for eye, we did a scleral patch graft with AMG in the left eye. And on 4th day post-op, we noticed that there was a small lesion appearing in the right eye also. And
I'm so sorry, Pooja ma'am, but kindly wrap up in next 30 seconds, or we are up with the time.
Okay, so this is the clinical picture of left eye, and here we can see after starting the topical steroids, the lesion has cleared. And we can see the systemic lesions also has started disappearing. So our diagnosis was Behçet's based on this criteria, which is international criteria for Behçet's disease. So here criteria are given based on genital aphthous ulcer, scores are being given. So based on this criteria, our score was 6/8, which was diagnostic of Behçet's criteria. Here they say 3 or more points give the diagnosis of Behçet's disease. So there are certain review literature. So here in pediatric patient, mostly pan-uveitis and anterior uveitis is more common, but our patient was presented with PUK. So take-home message is that this case is reported due to paucity of data on bilateral presentation of PUK with Behçet's in a pediatric patient. And Behçet's disease is a multifactorial disease which can affect most organ systems of the body with unusual presentation, and multidisciplinary approach is required for precise diagnosis and management of these cases. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Pooja. It was a very nice presentation.
Thank you,
Dr. Anuradha, is she ready?
Yes, sir.
Okay.
Am I visible, sir? My presentation visible?
No, it's not visible.
Not visible.
Right, one second.
So shall we continue with the other speaker, or would you like to wait?
We should continue with
Okay,
the next speaker, I think.
Sure, sir.
Yeah. So our next speaker is Dr. K. Priyadarshini, oculodermal sibling with lentigo maligna. Dr. Priyadarshini.
Is Dr. Priyadarshini there?
Speaker is yet to join, sir. Can we call next speaker, sir?
Yeah.
So our next speaker is Dr. Nimisha Nagpal, atypical eyelid infestations. Dr. Nimisha.
Not present, sir.
Okay.
Dr. Ravi.
Next. Is present, sir.
Yeah, we can go ahead with Ravi then.
No, sir, no. Not present, sir.
Ravi
Absent, and Dr. Akshit Chawla also, sir, absent.
Absent. Okay.
So the discussions need to happen, sir, for those presentations.
I think before that we'll finish off her presentation, no?
Yeah, we can wait for
Yeah, Dr. Anuradha.
Yeah.
Anuradha. Okay. Dr. Muralidhar sir was asking a question. Probably meanwhile we can take that question to the participant.
We can start the queue. So we can probably, I think she's joined.
Okay.
I have joined back, sir. I'm so sorry for causing the trouble, but I'm having some issue with the present sharing of the screen.
So ma'am, are you able to solve it, or shall we continue?
Yeah. No, here I am. Can you see it now?
Okay, yeah.
All right.
Yeah.
Thank you so much.
Okay.
Good morning, everyone. Thank you so much for being patient with me. So ophthalmomyosis is the infestation of ocular structures, any of the ocular structures with larvae of various species of the fly. And they are an uncommon entity, probably because they are mostly underreported group of disorders, have been characterized into external, internal, and orbital myosis, depending on what part of the eye has been infected. And today I shall be presenting a case of 3 cases of external ophthalmomyosis that we treated in Pathankot in Punjab, which were found to be caused by the larvae of Estrus ovis fly. For the sake of brevity, I would like to first explain the cases and then move on to the management and discussion. My first case was a 45-year-old male. He gave a history of something striking the left eye but not entering while working in the garden outdoors. Thereafter, he developed intense irritation, redness, watering, and a characteristic crawling foreign body sensation in his left eye. When we examined him under the slit lamp, we found multiple translucent larvae, rapidly motile larvae in the palpebral conjunctiva. Here we can see one. They demonstrated aversion to light, to instillation of topical anesthetic, and when we attempted to remove them using fine forceps, they tended to adhere to the conjunctiva. Here we can see one of the larvae. It is got, this is the head end, the black dot is the head end with which it is adhering, and this is the body. And the other one, other larva can be seen here. The second case was a 32-year-old male. He presented with acute onset redness and pain in the left eye. He did not give any history of a foreign body entering his eye or striking his eye. He washed his eyes with water. The symptoms relieved partially, but 1 hour later they aggravated with intense pain and a characteristic foreign body sensation, crawling foreign body sensation in the left eye. So on examination, again, we found similar looking larvae, mobile, translucent. Here we can see one migrating, trying to migrate in the medial cancers, another one trying to migrate in the superior fornix. And they demonstrated similar properties as the previous case. In this patient, it took us 1 hour and 3 attempts to remove a total of 12 larvae from the left eye. The third case was a 28-year-old male. He gave history of, again, something striking the right eye while he was working in the garden. And he developed redness, watering, and foreign body sensation immediately. He washed his eyes with water, but the symptoms persisted. So he reported to us the next day, and we retrieved 3 dead larvae from the inferior palpebral conjunctiva and inferior fornix of the right eye. All 3 cases, the larvae were removed in entirety. We made sure we removed the entire larva, and the patients were observed in the OPD for 1 to 2 hours so that any larvae which had migrated into the fornix could be retrieved later. Thereafter, the patients were started on topical antibiotic and lubricating agents and followed up over a period of 2 weeks. The larvae were mounted on slides under saline and sent to microbiology laboratory for species identification. Here I'm trying to show one of the larvae more clearly. It has got a translucent segmented body, a cephalopharyngeal skeleton, oral hook-like structures, and if you can see, there are fine linear sinus processes coming out from the intersegmental areas. In the laboratory, they were found to be 1 to 1.2 mm long larvae with segmented body, sinus processes, and retractile hooks at the oral end. They had a cephalopharyngeal skeleton, and they were identified to be larvae of the Estrus ovis fly belonging to the order Diptera. So external ophthalmomyelitis is uncommon in the sense that it has a reported prevalence of less than 5%. Tropical areas, hot climates, overcrowding, poor sanitation, immune compromised, debilitated patients, open infected wounds are more prone to infestation by larvae. The 4 flies of the order of Diptera have been found to be associated with ophthalmomyelitis, of which Estrus ovis, or the sheep nasal bot fly, is peculiar in the sense that it injects a jet of larvae into the nasal cavity of sheep on proximity, and actual contact may not be necessary for them to deposit their larvae. Humans are accidental hosts of this fly. And so finding 3 cases in a very short period of time was a little peculiar to us. So as I previously explained, the larvae are 1 to 1.2 mm in length. They have a segmented body, a cephalopharyngeal skeleton, and intersegmental spine. Here I have put up 2 stills from a video under the microscope where we can see the larva demonstrating its retractile hooks. These hooks allow for adherence to the tissue, and the sinus processes that come out from the intersegmental areas allow for a vermiform movement. The larvae display aversion to light, instillation of anesthetic eye drop. They are rapidly motile. So it is very important for us to remove the entire larva in totality so that no pieces, oral ends are left behind, which may cause inflammation and ulceration later on. To conclude, external ophthalmomyelitis caused by Estrus ovis is peculiar due to its ability to deposit larvae in tissues without actual contact. So patients may not give any history of an insect going into their eye. The larvae anchor to tissues, so it is difficult to remove them by washing or by a cotton swab. They require forceps to be removed. And while using forceps, we need to be very sure that the entire larva has been removed. And patients should be observed for some time so that any larvae which are hidden in the corner facing complications. These are some of my references. My sincere thanks to Dr. Vaidehi, who is presently working in Department of Microbiology at Jodhpur. She was there in Pathankot with us at that time, and she had helped us in the identification of species. Thank you.
Thank you so much, ma'am. It was one of the loveliest presentation, and so everyone, thank you so much for finishing it on time. Now we have time for Q&A. So I know there are a lot of questions, but only 1 to 2, 3 questions will be taken since we are still restricted with the time. So please stick by to the time, and that's all. Thank you.
All the other participants are absent, is it?
I mean, yeah. Can you just tell us the name of participants who have not? I think Dr. Vinod and.
But can we just mark them as absent?
Absent till now.
Vinod and Kshanam, Prava, Priyadarshini, Nimisha, Ravi, Akshita, they are all absent?
Yeah, I repeat,
They
sir.
haven't joined,
Dr. Vinod is till now absent.
Okay.
Dr. Nimisha Nagpal.
Yeah.
Dr. Ravi Vaishya.
Dr. Akshita.
Dr. Akshita Chawla and Dr. Priyadarshi. 1, 2, 3, 4, and 5.
5 are absent, no?
5 are absent till now. The
Yeah.
session time is up to 9:55. Maybe what happened earlier days, they might be having presentations in other halls. So 9:55 we will wait. Meanwhile, sir, for the participants who have presented, you can initiate this session.
Okay. Okay.
Thank you so much.
I have a question for Dr. Jyoti. I mean, don't you think use of diathermy would cause more inflammation? I mean, you have mentioned issues of cost and other irritation with use of Vicryl or glue. Don't you think, I mean, use of diathermy would initiate more inflammation?
Sir, can you hear me?
Yeah.
Actually, there is not much of an inflammation that I saw. Actually, we have a lot of experience in treating trauma and conjunctiva. Conjunctiva has a lot of healing capacity. So after diathermy, I have not noticed any extra inflammation or increase in any rejection of the graft or basically, graft falling off. And the only thing is you have to make sure that the edges of the conjunctiva are nicely apposed and they are dry before applying the diathermy. That's all.
Any issues regarding scleral necrosis or anything with the use of diathermy?
Not at all, sir. Not at all. Not even a single case I noticed that.
What is your experience with the autologous serum, madam? Autologous
Serum. I have done autologous serum, but I have my experience not. I can say that I did around 25 odd cases. But the thing is, what I noticed is there used to be a lot of pooling and conjunctival edema after that, and the graft used to be red for a very long time. Patient used to be very troubled by it. So I felt this was a more neater and a cleaner way, and patients were also very satisfied. And of course, glue is the best. Glue is the best, but then it is very expensive. This is very less time consuming, and as an alternative, it would be very good.
Like in the areas where you are applying the cautery, ma'am.
Sir.
Are there any projection kind of a thing, or it is planar?
No, sir. Once I harvest the graft is a little larger in size. So we pull up a little bit of conjunctiva from the edge of the bare sclera area, pull up this particular graft and dry it with the Johnson bud and apply the diathermy. So it stays there. That's it.
Oh, so in the limbal area also you're applying the diathermy?
Yes, in the limbal area also I'm approximating it to the conjunctiva only, not to the bare sclera, not to the limbus. So we're just pulling up the conjunctival edges on either side and drying it and applying the diathermy. That's all.
Yes.
Any chances of a graft rejection, madam?
No, sir. One odd case, the diathermy which was there, it was like the graft kind of did not approximate in one edge. Then the second day when I opened the patch, I used to just tap it with a Johnson bat, again put the patch, and the next day it used to be absolutely normal.
Any graft retraction?
Not at all, sir.
Not at all. Okay.
No.
Thank you. Yeah.
Thank you, sir.
I have a question for Dr. Suganya. I mean, generally, mitomycin C is not preferred in, pterygium surgery because it induces a lot of scleral necrosis.
Yes,
so,
sir.
Yes. So, why should we be using mitomycin C? I mean, amniotic membrane, I can agree. There are a lot of case reports of use of amniotic membrane, but why use mitomycin C when you have so many alternatives?
So basically, it was a study to develop a new procedure. Here, the mitomycin C, which was used, the contact time was kept limited up to 3 minutes. And we were seeing if there is any recurrence to it because no graft is used in that surgery. And so no sutures are there. So it's a sutureless surgery. And the time required for the pterygium surgery is very less as compared to the ones with the conjunctival autograft as well as amniotic membrane grafting. So that is the reason we tried using mitomycin C.
I would still say that the use of mitomycin C for 3 minutes, it's a large time. And mitomycin C may not. Why didn't you compare it with autograft? I mean, why with mitomycin C in particular? Because you wanted it sutureless? That's why?
So we had another study for conjunctival autograft. So actually, the entire study was comparing all the 3 procedures. So we also did a study by comparing it with the conjunctival autograft. So the results are almost comparable in conjunctival autograft also.
Yeah, Dr. Sukanya, I too agree with Dr. Muralidhar because mitomycin, I think we almost stopped using it 4 or 5 years back for pterygium. Conjunctival autograft, as you are telling, you are planning to have a sutureless thing. I think in conjunctival autograft itself, maybe something like autologous serum or what madam has tried, that you can, because conjunctival autograft has a proven track record, even when you compare it with amniotic membrane.
Yes, sir.
Yeah. Good. Anyway, good presentation.
Thank you, sir.
I mean, I have a question for Dr. Vijaya. I mean, you have said that smartphone is causing a lot of dry eye and this thing. So what are your recommendations for treatment?
So actually, what has happened is that this is a new thing which has come up. We've all looked at all studies. Everybody's looking at laptops and other devices. But we added a small clause for the mobile phones, and it was too less actually to take it up as a thing. But I do plan to take this up and look at this particular to yield better results. It's too early to say this is the factor and this is what we need to do. So I will be taking this up, and that is what I found out, the only thing different from previous studies. So it's a useful point because we're now all on mobile phones. That is probably coming up more, and we have to look at how we can do, not only for adults, but also looking at a study for children who are now on online classes on mobiles. So that is probably my future plan, but not at this point yet.
Dr. Vijaya, I think in your future prospective study, you should look specifically into active screen time and passive screen time. Active screen time is this online education where they constantly have to look. Passive screen time would be the entertainment part where they may not concentratedly look. So if you can subdivide it further, it will have more value. So for your future things, try to divide it into 2 times so that you get a better outcome.
Thank you, sir. Yeah, thanks.
I have a question for Dr. Sandhya Gaur. What was the final visual outcome of your patient? I mean, it was a very interesting case presentation. Bessett's causing ocular surface, I mean, scleral melt is quite rare. Normally, it causes anterior and posterior uveitis. But what was the visual outcome in your child? And what was the follow-up duration?
That was Dr. Pooja, I think.
Yeah, the Pooja Kumari was the presenting author. Yes. Sandhya Gaur is the co-author.
Yes, sir. So, when she presented, her visual acuity was hand movements close to face, and once we did the scleral patch draft, Then she gained a vision of 2/16. So later on, we saw that again the graph was melting. So we had to redo the surgery. So she was operated thrice in that same eye. And last visual acuity she has gained was 636. And she's waiting for contact lens trial. So because of this COVID situation, she's not able to follow up with us.
So what is the literature? What does the literature say? You would have done a thorough literature search, I'm sure.
Yes,
so
sir.
what does the literature say on Behçet's disease with scleritis, necrotizing scleritis?
Yes, sir. We could not find any case report with this kind of presentation. One case report which I had shown, they presented with bilateral PUK kind of picture, but that was seen in a 75-year-old patient, and he was already a confirmed case of HLA-B51 positive. But in the pediatric age group, I could not come across any case report with this kind of presentation.
Did you study any HLA associations in your case?
Yes, sir. It was negative, sir. It was negative.
Very nice presentation.
Thank you, sir.
Any other questions? Okay. So I think we are pretty early to finish this. Congratulations, team.
There are 5 absentees. Obviously.
Yeah, a lot of absentees. I see that.
50% is after
judges requesting you to kindly you can turn off your camera a little bit waiting, because if other participants are presenting in some other halls, they may join.
Okay, we'll wait.
We are supposed to wait till 9:55. Is that so?
Sir, it's up to you. If you turn off, if somebody
We'll wait
comes,
till 9:30, sir.
It happened yesterday, sir, that 2 contestants came in the next session, just 10 minutes before the scheduled time to be end. So another 5-10 minutes, if you can.
We'll wait till 9:30.
Fine, sir. That's fine.
Yeah. We'll wait till 9:30 and.
Yeah. Thank you so much, sir.
Thank you so much, team. Thank you.